Okay, so we can start. So I think it's important to know when biomarkers, imaging biomarkers, because it's the field I'm talking today, are necessary in the workup, in the process of the diagnostic process of Alzheimer's disease and in general for patients with cognitive impairment. So I think it first should be clinical evaluation, different tests, this standard test that should be performed, including MRI or neuropsychological evaluation. And then when the diagnosis is not so clear or unclear in general, or the etiology, I mean, is when biomarkers are important. So these are the biomarkers that we have in nuclear medicine and molecular imaging, particularly using PET, positron emission tomography. The amyloid A, the tau T, and the N neurodegeneration using metabolism using FDG. In the bottom, you can see here the comparison of just one single patient. This is one slide, and with a normal database. This is a statistical surface projection. This is the usual way we are reading the exams. So we compare this patient, and these are statistical differences with a normal database. There is a clear increase in the cortical deposition of amyloid. This is the same for tau, and this is the other way around. So this is hypometabolism in the frontal, where the tau is uptake, or the tau is increased. So this is the way we are doing. This is the different topics I'm going to cover today. So let's start by amyloid. So amyloid PET, we have 3 tracers approved in Europe. We have the florbetapir, flutometamol, and florbetapine. All of them have a very high accuracy in the diagnostic of Alzheimer's disease pathology, and this has been validated against necropsy. So this sensitivity and specificity has been demonstrated in patients that they were scanned before that, and then after the necropsy, they compare the findings in the PET against the findings in the necropsy. So I think this is really important. The other thing we have to highlight here is there is no contraindication for these exams. The variability, not only inter-center, but also individual variability, is very low, and the reason for that is for sure because they are very great radio tracers, but also because we have a very well-structured imaging reading of these images. The other thing we can give to the patients is we can follow up the changes, and we can, as you can see here, see where is the location and also the extension of the amyloid burden. And also now we can talk, because has been approved in the EU and in the European Union, this modifying these treatments against amyloid for the patients with Alzheimer's disease or cognitive impairment. Well, these are 3 examples of these 3 tracers about how is the color scale for florbetapir, florbetapine, and flutometamol, different color scales, different way to present, but this has been approved by the agencies that approve these tracers as a medicament, and also the way we are have this structural visual analysis. And we have to classify patients as positive for a very high or elevated amount of amyloid plaques, and negative means scars or non-amyloid plaques in the brain. So this is the classification. It's a binary classification for the amyloid. But what is important to know at this point, this is the clinical practice, but we have a universal, approved by the European Medicines Agency scale to quantify the amount of amyloid that we have in the brain. So this is, I think, important because this is a clear expression of the continuum of Alzheimer's disease. So this is known, 0, and very high, 100%. In the mean, you can see different amounts of amyloid burden. So, and this has been also developed with different initiatives like AMIPAD and also by others. And I think it's important to have this universal metrics to evaluate the quantity of amyloid, not only to a binary classification, but also two different ones. And the reason for this universal is because we have 3 radio tracers approved, as I told you before, and probably the distribution and the reference region of interest or region of reference is different. So we put all together in just one value. I think this is important as a metric to evaluate, and this is the metric that has been used in the clinical trials. We are working with this centiloid scale in our experience. So this is a very early study. We started with MCA patients. This is a study in collaboration with Siemens, and we are going to calculate the different cutoff and different points according to the ROC curve and according to the visual evaluation as positive and negative. This is the population. As you can see here, the negative read is -8, could be this value. 58 for the positive, and 28 where the 2 evaluators had no consensus, only 8 patients, but there were no consensus in the 2 independent readers for these 8 patients. But look at the numbers are absolutely different. So this is in the middle of between those 2. But there are other information here. Look at this, -51 to 39. Wow, it's a long distance. So the median is -8. Most of the patients are here, but the range are this, 10, 127. So there is something that is not clear for the visual reading. So probably some patients, not only in the in the non-consensus, because it's from 8 to 90, but also here there is a huge difference. And this is probably the message I want to give to you all, the importance to quantify the centiloids. These are the continuous in different, these tracers, the 3 tracers. We were evaluating these 3 tracers, and these are the values. So you can see clearly how is the amyloid progression in this continuous of amyloid. This is the ROC curve for a diagnosis of 0.98. So it's very high according to the visual classification. And the cutoff was 26, which is fine. But there are a gray zone. This is also, I think, important. So patients between 11 and 39, they don't have 100% of the classification, so the accuracy is not 100%. So this is called gray zone. And look at how this negative, gray zone, and positive are differentiated in this cohort of patients. I think also is important. I think it's particularly important, this population. And if we go for this graphic, you can see here how patients visually classify as positive have 9 centiloids, which is really, really low. This is a clear negative. I don't know what was the reason for that. But also this patient was visually classified as negative, but they have 39. So I think this is probably the information is given by the centiloids, by this gray zone. And also there is so influence in the predictive value of amyloid burden using PET. This is the visual, clearly different between negative and positive. This is something we can expect. These are MCI patients because we follow this patient and we have how they convert to Alzheimer's disease dementia. But here, look at there is clearly negative, clearly positive, different curves, but there is a different one for the gray zone. So probably the progression in these patients with less amount of amyloid are slower than those who are clearly positive. I think this is something probably in the clinical practice could be interesting to know, particularly when these new treatments are available. Let's move to tau, the T. We have approved it in the last year, at the end of the last year, here by the European Medicines Agency, the tau bit. This is the commercial name, this fluortaucipir, and these are different examples for healthy controls, MCA subjects, and Alzheimer's disease dementia. So as you can see here, there is also a progression from the medial temporal to lateral temporal, and also other cortical areas, according to the progression of cognitive impairment. However, you can see here, this was approved by the FDA in 2020, but last some years, additional years to be approved by the EMA. But what I want to highlight is that this tracer has an off-target binding. Look at the basal ganglia. This is a healthy control, and this is Alzheimer's, and this is MCI. All of them have high activity in the basal ganglia. This is off-target binding. This is not tau that we want to measure in the medial temporal or other neocortical areas. There are other tracers now in development, in approval by the agencies, that probably there's a second generation of tracers that this off-target binding is less, I think more feasible for the clinical practice and reading. But anyway, so this has been demonstrated, and this is the tracer that we have approved here in the European Union. And this is the study that this approval was based. So this, again, like in amyloid, the EMA required this autopsy, confirm or validation of against autopsy for these findings. And they also have a very well-structured visual reading for tau positive and tau negative. And this is the sensitivity for 5 raters, is sensitivity of 92 and specificity 80%. And I think it's quite good for the evaluation of tau burden in patients suspected for Alzheimer's disease. In addition to be positive or negative for this Alzheimer's disease pathology, which is the neurofibrillary tangles, also we can see using PET the distribution of this tau. And the distribution is different according to the phenotype, the clinical presentation of the syndrome of cognitive impairment. So as you can see here, this is the typical posterior cortical atrophy, where the tau is high in a high amount in the posterior parietal and temporal occipital. This is logopenic variant, amnestic Alzheimer's disease in the temporal, and others. So this is also important for the differential diagnosis and also to predict probably the progression in these particular patients, and also the syndrome that sometimes is difficult to get at the beginning when the symptoms appear in the very early stages. And this is another point that the tau PET could be useful. This is the study of donanemab. Donanemab is one of these disease-modified treatments against Alzheimer, against amyloid. And they define that, or they randomize the patients according to the amount of tau of the patients. So not only be positive for amyloid using PET, but also they perform a tau PET at the beginning in order to stratify and randomize the patients. So randomized by low to medium tau burden, and also very high tau burden. And these are the results. So the percent of slowing is higher using when this treatment has been used in patients with low to medium tau burden. But when you combine all the population, all the high, low, and medium, the percent of slowing is less. I think this is giving us some ideas how can we use this tau tracer, tau PET, in order to classify and randomize or to select the patients who are going to benefit more about the treatment. Let's move to FDG. FDG is important because FDG is one of the most available tracers. It's the one we are using in all PET centers in the world, and is probably the cheapest for sure, and also the more available. And it's giving us the information about the neurodegeneration. Using FDG, we can also see the continuum of Alzheimer's disease, the continuum of neurodegeneration in Alzheimer's disease, as you can see here, at different stages. And this has been also proved against, against autopsy. So it's a specific tracer that has been validated against autopsy for Alzheimer's disease patients. So this pattern of hypometabolism in the posterior part of cortical association areas, temporal, parietal, and posterior cingulate, is a typical pattern that is specific and is also seen in patients, has been proven after autopsy. And FDG has also proved to be more sensitive, more accurate than MRI, because MRI is also showing the atrophy in the brain, so the decrease of neurons, and is also more sensitive and more. So we can see this pattern very early in the beginning of the stages, very early stages, and the pattern is different, for example, in early onset and late onset. Early onset probably is a patient with a more advanced disease, but clinically, due probably to this cognitive reserve or other things, are presented this very high decrease in metabolism. A patient with similar symptoms, but in a late onset, could be less, if hypometabolism could be in a less degree. So with FDG, we can also see this neurodegeneration present in this patient at the very early stages. But we can find a patient, MCI patient, for example, positive for amyloid. These two patients are positive with flutometamol and fluorvitamine. And these are different results in the FDG study. So this patient has the typical pattern of parieto-temporal hypometabolism, and this pattern hasn't this pattern. So what is the meaning of this? Because they both have amyloid positive. So probably the prognosis of this is that this patient will be converting to Alzheimer's disease dementia in a short period of time than this other one. So this is more or less the information, the predictive information is given by FDG. And FDG is also helpful for the differential diagnosis. And here you are really experts in this, because this paper has been published by Michel. And this is a very nice paper because they demonstrate that these patients that a few years ago, everybody classified as Alzheimer's disease, they demonstrate that this is not Alzheimer's disease, this is this late or limbic age-related TDP-43 encephalopathy. And these patients have a typical pattern of hypometabolism in the medial temporal and also in some limbic areas in the frontal. Different from the Alzheimer's disease, this is the statistical decrease in the temporal parietal, but there are also some additional patients with a combination between Alzheimer's disease pattern and this hypometabolism in the medial temporal lobe. And I think this is important because FDG could classify or identify this patient in older patient clinical genetic and molecular biomarkers that underline this, late pattern validated also with necropsy. We are working with that, and we want to collaborate with you in this endeavor. I think we are studying this population of 200 mild cognitive impairment patients, and we perform FDG and amyloid for all of them, and then follow up from a long period. In this case, I think this is a medium, 24, but could be in some cases more time of the follow-up. So what we found after classify the patient visually using this statistical surface projection. So it's a semi-quantitative evaluation of a single patient comparing with a normal database. And then once we classify according to the pattern defined by Michelle, we also validate this using SPN as a group. So the pattern was clearly similar that has been demonstrated in Alzheimer's disease dementia or patients with dementia. These are MCI. And these are the differences between groups. So late has a hypometabolism more clearly in the medial temporal. Alzheimer's disease is clearly more hypometabolism in the parieto-temporal and posterior cingulate. Similar findings could be seen in this mixed pattern with Alzheimer's disease plus, in some cases, this medial temporal. Well, when we evaluate the clinical characteristic of these cohorts of these groups, we found that the minimental was higher in the group of late, like pattern, than the Alzheimer's disease and mixed Alzheimer's disease plus late. And also the amount of amyloid positivity was less than in the other two groups. And also the centiloids are in 8. Sorry? Yeah, absolutely. Yeah, it's incredible, yeah. But look at these ranges. They are clearly negative and some in the gray zone. And that's why we also wanted to know how was the progression to Alzheimer's disease dementia or general dementia. And the group with late pattern, they, well, as you can see here, after 2 years, here in the middle, the percentage of conversion was 19, 50, and 44. So clearly different. And when we go to the median of progression, conversion to Alzheimer's disease was 78 months, 23 and 24. So 2 years, and this is much more longer. And also the risk of conversion at 3.4 times more frequent in the group of Alzheimer's and mixed when you compare with the late. So I think FDG is also very helpful to identify these patients that in the past was classified as Alzheimer's disease, and now we know that they are late. They are this limbic encephalopathy related to TDP-43 burden. Finally, I want to discuss a little bit and put together all this information I'm giving to you today about this 8 of amyloid T, of tau, and N neurodegeneration. And for that, I want to mention this presentation that was, this is the idea of the Alzheimer's Association and National Institute for Aging in the US. They suggest to base the clinical diagnosis of Alzheimer's disease exclusively in biomarkers. So they say clinical, well, it's important because it's a syndrome, but the etiology can be only identified by biomarkers. And they propose biomarkers CORE1, CORE2 in the field of Alzheimer's disease pathology. CORE1 include CSF and plasma, and imaging for amyloid. And for CORE2, these are the diagnostic biomarkers. And this could be part of the completion of this diagnosis, but also giving additional information about prediction. And these are biomarkers not specific in the process of Alzheimer's disease pathophysiology, and also other biomarkers in non-Alzheimer disease, but could be reflect co-pathology, which is not infrequent in this. So these are my questions for this. First, are similar the amyloid we are measuring using fluid than the amyloid? Second question, are amyloid soluble similar to tau2 amyloid in this relationship? So this is a clear example of how amyloid PET is not exactly reflecting, or CSF is not reflecting exactly what we are seeing in a amyloid using PET. This is a study of 700, more than 700 subjects with amyloid PET and CSF. And when they classify the CSF as positive, negative, and also the PET amyloid as positive and negative. So patients with CSF positive for amyloid and PET positive are in red. This is the progression or the conversion to Alzheimer's disease dementia. But patients with CSF positive but PET negative are in yellow, and yellow is similar than those, at least the percent of progression is after some years, are quite similar to those with CSF negative and PET negative. So probably CSF is more sensitive in order to evaluate the amyloid, and is for sure evaluating the amyloid in soluble amyloid, not exactly plaques. This is the experience of Matthias Brendel, that you mentioned today. This is the experience of a hospital in Ludwig Maximilian University in Munich. And they studied along 10 years in a clinical setting, patients that perform amyloid and CSF, the same patient at the same time. They found that there are patients clearly negative for CSF and clearly positive. Look at the results using PET. Those negative for CSF, most of them have negative PET. Only a few, 6% probably variability. But look at the positive. The positive, most of them were positive, so the relationship is perfect. But there are more than this. There are 10 to 40% of patients. So there are more patients who are negative in this case. So probably it's reflecting the high sensitivity of CSF for soluble amyloid. But in the middle, so those who are inconclusive for CSF, the PET is classifying very well as positive and negative, and probably is half and half. I think this is something we can add to the CSF, because probably they are complementary. And for this reason, they suggest this paradigm in order to give the treatment, the new disease-modified treatment against amyloid for the patients if they are positive for PET, if they decide to go for PET. So you can treat the patients if the CSF is reflecting clearly negative, so we can exclude, and if they are positive, we can give the treatment. But for those who are in the middle, so not conclusive, we can use PET in order to start with the treatment. So I think this is a complementary use of the value of PET. And this is another study which is reflecting also the relationship between the amyloid measured by plasma, which is now very in a fashion way, because everybody is developing a test for plasma, which is obviously very helpful for classify the patient, for classify the population. And is amyloid PET similar to plasma? Well, they study 465 patients. According to these results, they define this prediction. For patients cognitively unimpaired, they found that using exclusively plasma and exclusively PET, it will be necessary a lot of studies. For example, using exclusively PET in unimpaired patients is for 4,500, and this is 5,500 for plasma, in order to identify 1,000 323 PET positive patients. But for those, but there is an amount of patients that the positive prostate will require confirmatory amyloid PET scan. I think this is the population that could be useful in order to identify the patients at risk that we should follow. And this is part of the practical clinical practice we can do in the near future. And for those who are cognitively impaired, look at the proportional between these two is shorter. So there are almost similar patients that we need a confirmatory PET if we use in the population the plasma or only the PET. So for sure the plasma will be cheaper. So probably if we select as a first part of this workup using plasma, then we will need a percentage of patients that will need to confirm this amyloid positivity in order to start the treatment using PET. And this is a summary of all this information. So we can summarize that we have fluid, CSF of plasma for amyloid, for tau, and also for neurofilaments. And they are all showing the soluble protein. But using PET, we are looking at the aggregated amyloid, tau, and this is the neurodegeneration. So these are some differences that could explain this difference that in the clinical practice we are also shown or has been described in the literature. So fluid biomarkers are Alzheimer markers validated against PET, but PET biomarkers has been validated against neuropathology changes, so necropsy. PET biomarkers allow assessment for quantity and localization of pathology, so it will be helpful also to evaluate this differential diagnosis, staging, and therapy monitoring. We need to know if this patient has eliminated all the amyloid in the brain, and then we can stop the treatment as donanemab suggests. And also there are some false positive and negative in fluid biomarkers depending on the comorbidity of the patient, the renal dysfunction or hypertension or particular some treatments. And so in summary, so I think equating imaging and fluid biomarkers neglect the complementary role or the complementary value. So going back again to this classification of neurotracers, I wonder why is tau PET not in the core one? Because there are other tau here. Wow. Well, look at this paper. It has been published afterwards, obviously. But anyway, they study this population, patients with Alzheimer's disease dementia, MCI due to Alzheimer's disease, non-Alzheimer's disease, and controls. And they explore the sensitivity and specificity for amyloid PET and tau PET. Tau PET dividing by if the tau is in the neocortical areas and also in the medial temporal. And look at the results. So the sensitivity is very close, only 80%, but 80% is fine for MCI. This is a combination of MCI plus Alzheimer's disease dementia, but specifically for MCI, 80%, 90% using medial temporal. Look at the specificity. Specificity is also quite similar, with the only exception of medial temporal. That's why tau-bit, which is the commercial trademark of flow-tau-supri, the tracer has been approved by the EMA. They suggest not use the medial temporal for the diagnosis of positive tau, because it's not so specific. And so we are using for the visual reading only the neocortical. So sensitivity and specificity is quite similar to amyloid. So I would suggest that tau PET should also be in the future part of this core one as a typical patient with tau 3 or 4 will be a Alzheimer's disease patient, for sure, particularly when we show this distribution. More, why they suggest MRI and FDG as a similar level? Probably this is wrong because FDG is much more sensitive and accurate than MRI in the earlier stages. And finally, why they don't include dopaminergic imaging while they are including synuclein in fluids. So I think this vision of experts of neurologists and nuclear medicine physicians, it was published some time ago, 4 years ago, almost 5. They define, or we define 3 different scenarios, clinical scenarios. One is when the clinician thinks that the most probable diagnosis is Alzheimer's disease. Then amyloid, using PET or CSF, will be first. But in some cases, defined here, we can use FDG because it's now available and it's cheaper. We can define, we can answer this question for the clinician afterwards. But if the most probable diagnosis is the syndrome is not related, clinically related to Alzheimer's disease, or is more open, could be other etiologies, maybe FDG will be more informative than amyloid at the beginning, and then we can confirm using amyloid. But if the patient has some movement disorders in the syndrome, in the clinical phenotype, so probably this presynaptic dopaminergic imaging, which was not included in this core one, neither do others, could be very helpful. Then we can classify the patient with FDG according to the different patterns, or amyloid, depending on that. And to summarize all the ideas that the experts had, I want to present this updated appropriate use criteria that was published, the first one, more than 10 years, 12 years ago. And now we merge not only the amyloid appropriate use criteria, but also the tau, because tau is now available. So the expert classify these clinical scenarios in 3 groups. Green is appropriate, this is uncertain, and this is not appropriate in red. And amyloid and tau is appropriate, or are appropriate patients with a typical presentation, for example, early onset, below 65 years, patients with atypical features, but also patients with the normal or late onset of the clinical syndrome. So in these cases, this is something that they modify, and we modify from the previous one, because I think it's important to confirm that the amyloid is positive in patients even with a typical presentation at a typical age. But also, probably will be appropriate in the future to use the tau. So the clinical expert in general from the Alzheimer's Association and Society of Nuclear Medicine in the US suggests to include both. And also for eligibility for amyloid therapy, as I mentioned, there are some drugs that they suggest to do that. And also for monitor the response. I think amyloid PET will be very useful in order to stop the treatment, particularly with donanemab. But the evidence of tau PET is not so frequent, or there are no so evidence in order to do that is a clear appropriate use criteria, but could be in the future. There are other scenarios. Could be the prognosis of MCI patients. Both tracers are really helpful. Amyloid, particularly when using centiloids, and also the tau. And in patients with dementia, probably amyloid will not be necessary, but tau, this different distribution will be very useful in order to predict the different evolution, the different how the patient is going in the future. So, and this is probably something that has been also included in my controversies that I have included in this presentation. So with MCI, patients with MCI or dementia with equivocal or inconclusive result of CSF biomarkers, amyloid is clearly important, but probably will be also tau because the evidence for now is not so high. So in conclusion, to finish this presentation, I want to say that molecular imaging using PET have a critical role in the diagnosis of neurodegenerative disease with cognitive impairment. And amyloid is an Alzheimer's disease biomarker, and this longitudinal extent and distribution of a form Alzheimer's disease pathology and important for therapeutic management of Alzheimer's disease. Tau is also an Alzheimer's disease biomarker with inaccurate diagnostic information with regional correlation with clinical phenotype, which will be helpful for the differential diagnosis. And tau precedes the neurodegeneration, so could be also accurate for prognostic information. And in the future, as I mentioned, could be served as an universal biomarker tool providing information about amyloid, tau, and neurodegeneration. Finally, FDG, we can't forget this tracer because it's very available and facilitates the differential diagnosis, and also is prognostic information or giving prognostic information about the short-term progression to dementia and staging for neurodegenerative processes. So I want to thank you all for your attention and for sure the team in Pamplona and Madrid. Thank you.
I will start with a very probably naive question, but we have a nuclear medicine physician here. So I wonder, it's time to do it. So you mentioned that you feel that second generation tau tracers will be more feasible in the clinic because they have a less specific uptake. And that may be true, but most of the uptake that we see in all the amyloid tracers is 90% in a specific. So the extent of the specific uptake is very limited to the cortex, and most of what we see usually is in a specific. So why is this, from a nuclear physician perspective, a problem for the tau evaluation, but not so much in amyloid?
Well, I show you that this tracer has been approved by the EMA, present off-target binding clearly in the basal ganglia and the striatum, but they are also in other parts. So I think it's not so easy, and the amount of tau is not so high than the amyloid. So probably the tau is more the distribution than the amount, like in amyloid. Amyloid is the quantity of amyloid. Doesn't matter if this is in the frontal or other areas, but the tau has a clear relationship with the phenotype. So I think as much clear are the images, easier to identify the different Bragg stages, and if this is has also for quantification. But I think I really didn't understand you when you mentioned that this is in a specific. You mean the off-target binding,
Yeah.
or okay?
So most of the binding that you see in amyloid is also off-target. For example, in the white matter, it's all off-target binding, and it's not really a problem for the clinical application.
Yeah.
Of the amyloid.
Because we are looking only on the gray matter.
Yeah, I think that's a good point. I think the main difference is that in tau PET, the non-specific binding coincides with potential regions of interest, whereas we're usually not interested in white matter, so we don't care about non-specific binding in the white matter.
And we can segment the study.
So I have another question, which is pretty much geared towards a nuclear medicine as a specialist, taking advantage that we have you here today. You mentioned the standardized reading of amyloid PET scans, and there's also a standardized form for reading tau PET scans. And you mentioned that this helps a lot in the clinic to make results comparable. So how is that for FDG PET? because FDG PET, you mentioned that it is rated as positive or negative,
Yeah.
but not only positive or negative, it's rated
Yeah.
positive for some specific pattern or another. Is this something that is included in the nuclear medicine residency training, or once you start in the nuclear medicine department and start with evaluating dementia scans, someone will show you how to evaluate that, or how is it? If it's standardized, how and if not, so how is this? How are people trained on that?
That's a very good question. So maybe we can extend this question to lymphoma, lung cancer, or others. So that's why we are nuclear medicine physician specialists for 4 years. So we know it. So which is the responsibility of neurologists about looking at the patient with MCI, how they classify MCI or not early Alzheimer's disease dementia. So we can stand the question for everything. But for this, but you are right. So I think the FDG is not so easy to read. But if we are using this type of statistical surface projections, if we compare, this is a semi-quantitative information we are giving in addition to the visual reading of the slices. So I think this is quite important because in this statistical surface projection, we can see the pattern. And the pattern is easier to identify using this methodology, as has been also included in the guidelines of FDG brain studies published last year. The last, it was in November or October, I think. So I think we include this because I think it's quite important that patients with no so high experience reading FDG studies makes easier, or those patients who are not, I don't know exactly this is the posterior cingulate hypometabolism or not, look at these parametric maps. So probably using parametric maps will be helping those who less experienced readers. And probably we as a specialist in neuroimaging, we can also perform some courses like this for amyloid or tau in order to be an experienced evaluate or reader for FDG. So could be a good idea. But I think these kind of things are helping us more than requiring more efforts or whatever. I think it's important because I think probably neurology will trust more in the images if we are more stable reading FDG, which is not so difficult. But FDG has also some additional problems that, for example, amyloid and tau don't have. And they for example, using FDG, so the glucose levels are also critical, and also the treatment of patients are affecting the metabolism, not only the metabolism, but also the activity, the neuronal activity. So that's why probably in some cases, or vascular, for example, I don't know how vascular is, comorbidities are also influencing this. I think it's a good point. But in general, if we follow the guidelines for reading FDG using these semi-quantitative parametric images will be easier for everybody, for experts and non-experts. Good point.
I can imagine. I fully agree, because if you look at the raw images in an amyloid PET scan, either there's something there, there's not anything, right?
Yeah.
So in FDG PET, there will always be signal, and you're looking for reduced signal, and for that you need to have a mental representation of how a normal scan should look like to interpret a pathologic scan. So it makes much more sense to use a normal control database to make that work for you, right?
Yeah, but all the, so in the most of the workstation, we have this type of software. So I think more, for example, Siemens, GE, and others, and also, well, you have another software. So there are software that are helping this, and everybody is, I think, is using, because it's supported by the guidelines. We highly recommend this.
Related to, thank you very much, Javier. It was really, really great talk. related to Michel's question, I think we are here some supporters of FDG PET. I think this is the FDG PET corner, and I think we were discussing about that FDG PET could be more useful probably in clinic, especially now that the disease modifying treatments are coming. I mean you propose several places where we can use it, with neurologists can use it. I was thinking about the correlation with tau PET.
Yeah.
Because I mean it's like a mirror, right? So
Exactly.
and tau PET is going to be essential if we really want to select exactly when to treat the patients, because it's the best we have for the staging. But tau PET, unfortunately, maybe it's not that available, but FDG PET is really available. Could we use FDG PET to help us staging the patient, probably in addition to other markers?
Absolutely. So we have learned after using tau that this is a mirror. Absolutely. So where you see I think in the first image that I show you, it was the same patient with amyloid, tau, and you see hypometabolism with the tau is present. So the question is that tau is earlier, a little bit earlier. So could be more sensitive.
Yeah,
and more specific for sure.
I wanted to add, because I think this is a really interesting point, the difference between tau PET and FDG PET, because if it's just a mirror image, maybe a bit earlier, then the added value is not so high. But it's only mirror images. It is only a mirror image if there is tau.
Yeah.
You can, if you have Lewy body disease, or you have late, you have a neurodegenerative disease resulting in hypometabolism that's not related to tau, then the tau PET scan would but just be negative, and you still have a lot of hypometabolism, right? So it's only a mirror image if there's actually in the AD spectrum.
Why I think we should combine with, for example, p-tau 217, that you are sure that you are in the amyloid arena, and then the FDG PET is with the topographic side, meaning that. So definitely not alone, but maybe combined with a plasma biomarker, maybe.
I think in experienced hands, for example, a group who are focusing on this neuroimaging, I think FDGs are very powerful tool, for sure. And also we can start using these parametric maps for all the specialists. But yeah, absolutely. At least by this moment, we can say that FDG is particularly useful. Probably in the future, I'm a great defender of tau imaging, because could be in the future. But this is something probably I don't know I will see or not, because it's much more expensive for sure.
Actually, about the future of tau imaging, I always wonder. So you showed this very classical right now already diagram where you say, like, if the main suspicion for the patient is AD, it would make more sense to do amyloid PET first. And I have never followed the logic of this, because amyloid positivity prevalence is also very high in older populations that are cognitively normal. So a positive result will...
could be in a specific, could be copathology, for example, comorbidity.
It will be like...
That's why tau will be perfect for that.
So I have never get to the bottom of why this is the case, because it would make much more sense to do FDG first if you think AD is the case, because if you have an AD pattern...
But let's think in a particular patient, for example, 84 years old, which is now, well, many people with dying 100, 95 or 94. So 85 or 84 or 83 could be people reasoning very well. But in this patient with a mild cognitive impairment, and this population has the comorbidity could be higher than other groups probably. So I don't know if FDG will be the best, but for sure, I believe that tau in this particular scenario will be perfect.
Tau I agree, but amyloid, I found it very weird to be the first recommendation.
Because they are so...
amyloid positive may be common in this age,
And also the amount of amyloid in this high, at this age is not so high than, for example, at 65 or 61.
And
So the amount of amyloid is less.
Somebody might argue that without neurodegeneration, it is very unlikely that the amyloid positivity is the cause of the cognitive impairment.
Yeah.
But in that case, probably we should use not MTL tau, but cortex tau, right? Because if you only look at MTL, probably it's not that specific because of the parts and
the FDA label. This has been a very controversial topic for the last year and a half, and also in the Congress that we just came back. In theory, according to the FDA label of fluortaucipir, the MTL should not be considered. So what the label says is that fluortaucipir is able to detect advanced tau, and advanced essentially means BRAC 5 and 6, really in the neuropathological study that Javier showed the data. But it is true that in patients in earlier stages, we see a signal, probably more inspecific, probably more inconclusive, or circumscribed to a small portion of patients, but it's there and it's clinically meaningful in most of them, at least in a group level.
So this is the problem I find with tau PET, but I think that if it's positive, it's advanced. I mean, it's related to neuropathological 5, 6, BRAC 5, 6. But if we want to go early, it's not that specific. Absolutely. Because you have the part there which is troubling us. So this is a bit of a problem if we want to go as soon as possible for treatment. So this is why we should combine it with another biomarker and not do it alone, I think.
The big difference between the Alzheimer's Association group and international working group is if symptoms are present or not. So I don't know. Can we classify a patient just by the amyloid or as an Alzheimer's disease? Or I would say no.
I don't think so.
So with some symptoms, performing amyloid, we can just follow the patient. So maybe plasma or something. And if this patient is progressing,
I think we need to be more deterministic. We really need. I think we are not there for preclinical treatment. So only with amyloid, even with tau, I would be really reluctant to treat a patient with the medicine that we have now available, the anti-amyloid. I mean, probably if they develop an oral, cheap, and not dangerous treatment, okay, let's give it to everyone. But now I think we need to be much more precise, more granular to.
So
And
I think this testing is like really the interpretation is really different if you have symptoms, if there are symptoms or no symptoms. Because if you have no symptoms and you have a positive amyloid PET scan and a negative tau biomarker, whatever, that may just mean that's totally compatible with Alzheimer's disease, maybe Alzheimer's disease in early stage because there are no symptoms yet, no tau yet. It's okay. But if you have cognitive symptoms and you have a positive amyloid and a negative tau PET scan, then it's actually unlikely that the cause for these symptoms is Alzheimer's, even though there's amyloid. So if you have no symptoms, maybe preclinical Alzheimer's disease, maybe. But if you have symptoms, then it's actually unlikely that it's Alzheimer's disease. So it's a big difference. If you have if you're doing these tests in
with
someone who
with
has
symptoms
or not.
Yeah, that's true.
Thank you for your presentation. That's been clear and very informative from the practical perspective of a clinical neurologist. I have two marginal questions about the quantitative centiloid scale in the amyloid PET. The first one is about those cases with MCI in the gray area or gray range. You have shown that they have an evolution intermediate between those with high and low centiloid score. But do they have any clinical characteristic at baseline?
We didn't analyze this. I think we have the data, and will be really interesting to find if this group of gray zone are different. At the beginning, all of them were amnestic MCI, so not multi-domain. So I don't know. So maybe it will be interesting to check if they have a different phenotype from others. Or yeah, this is a good point to analyze.
My second
But
question.
the progression is absolutely different. So that's
Yes,
the
yes,
importance
I
of to measure the amyloid, not only as positive as negative, because for sure this is important. But I think with centiloids we have additional information.
My second question is about the centiloid scale with the three different markers, the three different amyloid markers. Do you know whether there is a good correlation between the three markers?
Yeah. So centiloid is so to calculate the centiloid in this scale, we are measuring.
Could you briefly describe
Yeah.
how the centiloids are calculated? Because many of us, at least myself,
So
we do not have a clear idea of how the scale
so
is
it's
applied.
very simple. So we for every single tracer, we have three. We have different region of interest in the cortex and a region of reference, and we are calculating the ratio between these cortical areas and the region of interest. For example, for frontal superior, the region of interest is the whole cerebellum. For florvitabine is the cortex of the cerebellum, and for flutemetamol is the pons. So we are calculating the SUVR, which is standard uptake value related to whole cerebellum, cortical cerebellum, or pons, depending on the tracer. So with these SUVR values, we apply a constant, which is some way putting all together in the same scale. This is the centiloid. In general, I don't know if you have.
Just to answer the question, the scale is specifically designed to harmonize between tracers. This is the goal. So you can establish common thresholds of positivity between the different tracers. That's
one additional aspect is just that for the centiloid scale, so it's not only the slope that all these tracers are on the same slope, but also their anchor points, where 0 means the average of healthy young adults. That should be negative. No auto, and 100 means the average of a typical group of 80 dementia cases. So you can have 150.
Exactly.
Or and that's why you can have -10, because it's just the average of these groups. So it's just, they call it anchor points. So that's interpretable what 0 means and what 100 means.
And there is another controversy if we should use the specific SUVR calculation for every single tracer, or use similar region of interest and similar region of reference. And this is more or less the debate currently. So probably the whole cerebellum is, I think Amipad is doing a great job in this area of calculating centiloids. I think it's more stable, more comparative, and part of the study we presented today, we want to see if this cutoff that we have for the SUVR for every single tracer are positive or negative using the centiloid. So things like that, I think we have to, has been approved by the EMA, so this is fine. I think the centiloid is giving us an additional value on the continuum of Alzheimer's disease, but I think we have to give more accurate data. But this question is interesting. I think, yeah.
I think we have a question online. I think it's the Dr. Merce Boada from us. So I think if she speaks, we can hear her.
Hello, how are you? Thank you for offering me the opportunity to talk with you. Thank you for this fantastic update, because one update is to create more and more hypotheses and more controversies. I back to from the Clínica that some of the attendees as formulate to you. The big question is how we can build an easy puzzle in order to understand the best radio tracer in the best moment, because we are talking about the FDG. I am a pro. I like to work with the FDG, and FDG is in the clinic is used for a specific disease, and no classical AD in order to get the best one diagnosis or one approach. The other thing is the use of the tau in order to understand the diagnosis of beta. Sometimes we only talk about A, but A is amyloidosis. AS amyloidosis, iron tau is P1217, 217, and p-tau really is a diagnosis of Alzheimer's disease. That is costly. It's not usually in every one of the centers, and we need more and more experience in order to introduce the both for the make the diagnosis. But FTG can be useful in order to understand the functionality of the brain, how is the metabolism of the brain, and the benefit, the meaningful, one of the meaningful benefits in the brain. That is a big question. And the big question is, we follow only the new core that the biomarkers have a solution, or we follow, for me, more rational and more affordable, and in terms of the clinical, more understandable, is to use clinical science, the phenotype plus biomarkers. That is one that is the new ways, and we need to reach the best one in order that every one country or every one institution can to work in the best way. That is, I have not a question. I have only one reflection about that very, very important topic, because this topic, we manage constantly this one. How is the offer? We know the offers. We know the meaningful biological benefits, but the transversability to move from the clinicians, that is very difficult to take the best solution, because one is in terms economic, another in terms of our experience to manage patients, another is when we introduce some topics like asymptomatic, like to monitor, like to understand the benefits, the meaningful benefits in the clinical. But really, thank you for this update, because if I have a DAP finish, I have more and more DAPs. Thank you a lot. And
Okay, so I try to define clinical scenarios as you suggested. For example, the appropriate use criteria. So we have different scenarios. I think, and what is useful in this clinical situation, and also these three different pathways for use amyloid or FDG also could be also useful for the clinical practice. But I agree with this. Is the patient first, and then you will see which tracer will be more useful depending on the clinical situation. I agree, absolutely.
thank you.
Ciao.
Hello, one last question. I don't want to bother you with more, but just for last one. Thank you again for the presentation. It was very interesting. I wanted to ask, what do you think could be like the role of novel PET radiotracers targeting emerging pathologies such as neuroinflammation or synaptic density? Could they maybe fill in the gap of amyloid and tau PET imaging, or are they going to be redundant? Like, what's your opinion about this?
Yeah, I have no clear opinion because I'm not using this tracers with neuroinformation. So I have no experience. I just only read papers. But I think there is something related with this. I don't know exactly how inflammation is acting. And my question to this is a specific biomarker for the disease? I don't know. So, but would be useful for research in order to evaluate how in this particular time point in the continuum is neuroinflammation important, and what is inflammation is positive or negative, is protecting or is against. Yeah, so it's not clear, but probably it's a very interesting part of the research, not exactly for the clinical diagnosis, but for sure for the research and probably maybe treatment. So probably I think we are in the first phase of the treatment for Alzheimer's disease since it was discovered 20 years ago. So we are so happy to have something to add to give to our patients, but probably in the near future we'll find, as you mentioned, other. And this inflammation will be an important part of the patient classification, or patient more feasible to treat with this drug or this other drug. Probably, I don't know.
It's still an unanswered question.
Yeah.
We'll see what the future holds.
I think, yeah. Thank you for the question.
Thank you so much.
I think we have to close here. Thank you. We cannot squeeze you more after feeding you.
Well,
you really hold your ground here. So thank you very much.
No, thank you for the invitation. It was a great pleasure. Thank you. Thank you for you all. Congratulations for your work. Okay.